The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Memorial Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
This episode of The Curbsiders is available for CME and mock credit through our partnership with the American College of Physicians. ACP members can go to acponline.org/curbsiders and claim their free CME and mock credit. Thank you and enjoy the show. Hey guys.
Hi. Hey. I hate that so much.
Me too.
Paul, you got to come in hot on these shows. Paul, you got to come in high energy. Really, yeah. Okay, I'm
Good
resisting
job.
a bad
convinced.
joke there. Yes,
I'm convinced.
you got to come in hot. So this is the Curbsiders. Tonight we're going to be talking about buprenorphine and opioid use disorder. With me tonight, multiple co-hosts. Stuart Kent Brigham. Stuart,
It's me.
how are you doing?
Well, thank you for asking, Matt.
Moving on to Paul. Paul.
I'm doing great, Matt. Thanks so much for asking.
All right, we'll introduce our guest host in a second here. Paul, can you tell people what we do on this show?
I often wonder. We are the Internal Medicine podcast, and we use expert interviews to bring you clinical pearls and practice-changing knowledge. I will generally give you a hard time up front about skipping past the first 15 minutes, which are pure gold about humanity and life, and they'll ultimately make you a better person, so stick with us, please.
Yeah,
Yes.
I think this week's first few minutes are kind of an extension of the show. It was definitely related to the topic, so I would definitely
Especially
listen.
the pick of the week.
Yeah. And now with us tonight, not the pick of the week. With us tonight is the great Dr. Justin Lee Burke, returning for his. He's been working with us for a very long time now. Just had a 2-year anniversary coming up here, Justin. I think.
Oh, wow.
Yeah. So
What do you guys give me?
tell the audience what are you up to these days, and then why don't you set up the show? Let them know a little bit more specifics of what we talk about tonight.
Yeah. So I recently started a new position at the Warren Alport School of Medicine at Brown University. It's the best. I'm getting to do some primary care, some inpatient care, some addiction work, which is a great segue into what we're talking about today at this episode. On this episode, we cover the basis of opioid use disorder treatment. It's great. We discuss, we address some of the knowledge that can be helped to empower providers to give confidence to start treating, including details on different formulations of buprenorphine, how to initiate treatment, how to address challenges that might arise on people that are on buprenorphine, and understand how to address things like perioperative pain management for patients on buprenorphine. Just an overall well-rounded way to become a master in all things buprenorphine.
That was phenomenal.
I think we succeeded. Paul, can you tell them about our guest?
Sure, be happy to, Matt. So Dr. Fingerhood is an associate professor of medicine and public health and the chief of division of chemical dependence at Johns Hopkins Bayview Medical Center. He earned his Bachelor of Arts degree from the Johns Hopkins University and his medical degree from the Albert Einstein College of Medicine. He completed internal medicine training and a chief resident year at Johns Hopkins Bayview. Dr. Fingerhood created the Comprehensive Care Practice in 1994, which is a primary care practice largely devoted to providing care to individuals with substance use disorder. The practice has been innovative in integrating buprenorphine treatment into the primary care setting for over 650 individuals. He also has co-created novel buprenorphine treatment programs at the community center, at a church, and in a mobile van outside the Baltimore Detention Center. He is the co-author of the American Society of Addiction Medicine Handbook of Addiction Medicine and the recipient of the Baltimore City Health Department 2017 Health Equity Leadership Award. So without further ado, and with great pleasure, we present our guest, Dr. Fingerhood.
He literally wrote the book on addiction medicine.
I was not going to read that joke out loud.
It's called
Right.
Addiction Medicine. I know. I
Tried
wrote
to
it.
stop it.
I'm making it insane.
It's just like a freight train bearing down on me.
There's this book called Addiction Medicine. On addiction medicine.
Mike, the first part of the show, we always like to ask our guests, can you give the audience a one-liner, tell them a little bit about yourself, and include maybe a hobby or interest outside the world of medicine?
Sure. So I'm a 58-year-old internal medicine provider. I'm at that age for another couple of days, who's devoted a career to the underdog. I really try to champion the care of patients with addiction and HIV. As you may hear as I speak, I have a Brooklyn accent that still comes out, especially when tired. So it's late in the evening now. A husband, father of two. I love to swim and run. And my most prized possession, which ties into my main hobby, is I have a basketball signed by the 1970 championship New York Knicks.
Okay.
Nice. So I guess I'll take my usual question. Tell me about a book that you feel like every doctor should read.
So this is an unusual book. Most people have seen the movie. It was just remade, but it's actually the book Papillon, which I read as a teenager. And there's a sequel also, Banco. I don't know if people have seen the movies. The original movie was a classic with Steve McQueen and a very young Dustin Hoffman. But the theme of both of them is really the fight for justice when the odds seem insurmountable. That there's a wonderful scene in the original with Steve McQueen at a leper colony and overcoming incredible obstacles to finally escaping Devil's Island, and then eventually getting justice and clearing his name in the sequel.
Spoiler alert.
So aside from that spoiler, what's your favorite failure? What'd you learn from it?
So my favorite failure is actually related to the topic I'm going to talk about. And it's happened more than once. So it just shows that you can make a mistake more than once and realize, that, why didn't I realize that? And that's work I've been trying to do, where I try to get community health clinics to prescribe buprenorphine, and not having insight into the kind of negative uptake and the indifference, because I didn't realize that they were first stigmatized against patients with opioid use disorder. And why would they want to treat opioid use disorder if they thought these were bad people who did bad things, who committed crimes? And I don't want these people in my office. So why are you telling me to provide treatment to them?
That's an ongoing struggle too, a lot of times.
Yes.
But we may get to this, but is that, I mean, it's certainly worth talking about, but is it really a mistake? Like, I just wonder if the exposure doesn't help sort of change the conversation a little bit. You know what I mean? I feel like the more you treat, sort of the more sensitive you become about using stigmatizing language and perception and sort of how to have the conversations. I don't know. I hate to hear it described as a failure, as maybe an opportunity for growth, but that's uncharacteristically optimistic for me.
I think the lesson I learned perhaps is that to first go in and assess where people are and understand what their views are, and perhaps later on, instead of me saying something, I brought someone in recovery with me, who perhaps there's validity to the reason why. I don't. This seems like a futile endeavor. If you've never met anybody who succeeded, you might think it's a waste.
Yeah.
So you've dedicated a career to addiction medicine and opiate use disorder. How did you first? What was your first exposure to opiate use disorder, and how did you kind of choose this field of medicine?
So my first exposure was actually back in 1974. I'm from Brooklyn, New York. And incredibly, I don't know this, it may be a coincidence, but it's definitely something that caused me to reflect that in 1974, in the apartment building I was living in, Flatbush area of Brooklyn, a methadone clinic actually opened in the same building in which I lived. I lived on the 5th floor, and a lot of the apartments in Brooklyn have kind of doctor's offices, entrances. Actually, when I was a little kid, my pediatrician was in the same building. But a methadone clinic had opened. And so this was 1974. It was, Vietnam War was winding down. It was really the first influx of heroin, although there was in the 60s too, because remember, methadone became a useful treatment in the mid 1960s. But it was the real need for methadone treatment. And what I saw, I didn't understand. And in fact, I didn't have a pet, but I remember neighbors being concerned because there were often almost empty bottles of methadone that were lying on the street, that they were afraid that their dogs would get into, because not all the bottles necessarily were fully empty. That was my first exposure. And I have to admit, by 1976, 2 years later, my parents moved. We moved to a different part of Brooklyn. So that was my initial exposure to opioid use disorder. I have to say, I was too young to really understand. I certainly didn't have a grasp of addiction. And then 10 years later, it's interesting, exactly 10 years later, I was a medical student in the Bronx at Albert Einstein. And this was the next wave, which HIV related to injection drug use. And also, at that time, injection drug use in the Bronx was just endemic. And our admission board, I did 12 weeks of medicine. On the board was a you put a diagnosis for each patient, and the most common diagnosis which was put on the board was SWAF, which stood for shooter with a fever. So it was a really dehumanizing term. And all you would see a person's name, SWAF, and name, SWAF, name. And we didn't do much. I mean, we did blood cultures. If someone had a murmur, we did an echocardiogram. And I remember saying to my attending, who was a rheumatologist, who was there because he was just there, what are we really doing for the patients? And he was kind of indifferent. And he told me that addiction was not a medical problem. That we were obligated to admit these people. He said in a kind of negative way, but there was no way as physicians we could do anything about what was wrong with them. So that kind of resonated with me because it didn't make sense to me. It certainly caused me to try to gain better understanding, but it also presented a challenge. And I always think that the most reward is when you try to solve the biggest challenges. So that's really, I saw it as a mission and a goal. If how could that be that I'm entering the field of medicine as an eager medical student and I'm being told that I can't do anything to help these individuals?
I don't want to get us too far down this now, but I mean, I feel like I have to respond with this thought that over the course of my career, which has been short at this time, I went from being a student to a resident to now an attending for the last several years. And over that time, the perception, or maybe just my perception, changed where these people are doing bad things and have bad behavior and will punish them by not giving them the opioids that they're seeking from us, to now where it's kind of shifting where, okay, these patients have an opioid use disorder. We have medicines that can help them. We can try to help them with this so they can get back on track in their lives. And it's just made the practice of taking care of these patients just so much more enjoyable. It caused a lot of distress during the times where the thought process was that, that these people were out of control and that their behavior should be punished, or it didn't feel good as the person who was supposed to be providing care for them. I'm not sure if if my colleagues
I think that's true. Yeah.
Yeah, no, I think I've said this before, and if any of the listeners out there want to take this research project and run with it, if I could just be in the acknowledgement sections, that'd be wonderful. But I really do think, I think using sort of patient-first language and treating substance use disorders in a humanistic sort of patient-first way, the relationship stops being adversarial, and instead you actually feel like you're meaningfully treating illness, which is the whole job. And I really do think it decreases burnout. It makes the job more rewarding, and it just makes you feel better about coming to work every day. So I would love to see a formal study that actually looks at sort of patient-first language and then just a sort of appropriate management of substance use disorder and relationship to actual provider burnout. And I bet you it helps.
Yeah.
So how would you randomize that? Someone's nice, the other person just kind of a not nice.
Not nice.
This is why I'm farming it out. Yeah, somebody else can figure that part out. You've seen me in statistics.
I'm with you. It's a great population to work with too. I think it is something that people miss out on if they don't get that experience in residency or in their training.
I've also just noticed that when you openly just talk to patients about their substance use and like say that, I want to understand what you're dealing with so that I can then understand. I want to talk to you frankly about how much you're using and what you're using, because I might have ways that I can help you be more comfortable while you're here in the hospital, or we can start you on buprenorphine and potentially help you, not have to keep going through this all the time. And patients just are like, some of them are like shocked when you're having frank conversations with them about this and like, just talking like you're on their side. It's very refreshing. If you haven't yet gone through it, and you're used to it going the other way, then please, I would implore you to try it out.
Is this the pick of the week? Your pick of the week is advocacy. It feels good.
Yeah. Did anyone have picks of the week? Because I think we should probably just move. I don't know. I feel like we've already kind of moved into the topic. So
Stuart has written an entire paragraph in this script. Are you sure you wanted to
about Miami Connection? Yeah. Okay. Miami Connection. Stuart, I watched that the first night I came to San Antonio, which was now 7 years ago.
You loved it, didn't you?
I did love it. It's amazing.
Yes. So Miami Connection is a quintessential 1980s film of epic proportions directed by none other than Richard Park, who directed such classics as Kill the Ninja and L.A. Street Fighter, and starring Y.K. Kim in one of his earliest English films. It's best understood by the synopsis on the back of its VHS tape box. It says, "The year is 1987. Motorcycle ninjas tighten the grip on Florida's narcotics trade, viciously annihilating anyone who dares move in on the turf. Multinational martial arts rock band Dragon Sound have had enough and embark on a roundhouse wave of crime-crushing justice." Anyways, there's more to it, but
we'll put it in the
you get
show
the
notes.
point.
We'll put the whole thing in the show notes.
Absolutely.
And the How Did This Get Made podcast talks about that on one of their episodes. It's amazing.
I don't know. I'll have to listen to that one. But
this may
the
be
box
the first
art
recommendation I've agreed with you on. So I'm pretty sure there was a bazooka involved, and if memory serves, I think there's a notorious snake in a toilet scene, which is also fairly spectacular. So
and an arm that gets chopped off. It's so 1980s.
Okay.
Cool.
Justin,
I want to do a quick shout out to an organization or online thing, GrepMed, GrepMed. We've interacted with them on Twitter a few times, but it's an incredible resource on social media for medical education, where it basically curates some of the best visual abstracts or schemas or images from echoes, EKGs, and has this wonderful way of voting system and saving and bookmarking to keep visual images that I think are really good for medical education. It was called the Pinterest of medical education in some article, like by Wired or Time or Washington Post or a blog, I forget. But you can make a Pinterest board for medical education. People should check it out. It's pretty great.
It's a great idea. Justin, so let's bring us into a case here.
So our first case today is Mr. Harry Goldfarb. He's a 28-year-old male who is struggling with addiction. He regularly uses heroin multiple times a day. He typically injects, occasionally with cocaine as well. He comes to the clinic because he feels like his life is just falling apart. He wants to get treatment. He wants to, take control of his life. What are some ways that we can approach him, and what are some current treatments that are available that we might be able to use to help Harry?
So I think the first thing to hear from Harry, he already stated, is that what his desire is to be patient-centered, person-centered, and to see what his goal is. I will often ask people, have they ever had recovery before? Because if they've had recovery before, I try to spin that as something that's positive and ask them to reflect on what helped them achieve some recovery time. We talk about what recovery is. We talk about support systems. Where does he live? Who's around him? Is it going to be difficult for him to achieve recovery if everybody else in his house is using? To try to do whatever he can to maximize his chance of success is what I always say to patients. And I often congratulate them for coming to get help, because I tell patients that I define recovery as making today better than yesterday. And you're here, Harry's here today. He realizes that he wants to get better. And I also define recovery as how people weigh risks and benefits. That the reason he uses heroin, cocaine is because he likes to get high, but getting into treatment doesn't mean that you didn't like getting high. It means that you want to get treatment, and he's going to tell me what the benefits of getting into treatment. So what does he think will happen if he's put on medication, for instance, to help him with his struggle with addiction? What's his goal? What does he hope to get out of it? What's he going to do with his time? How is he going to fill free time? Sometimes I say specific things like, it's going to be really great that you're going to wake up in the morning and not be sick and have to chase something. So sometimes I give out specific ideas, but I don't do that until I hear from the individual first. And then I ask what they know about treatment. So most patients know about both methadone and buprenorphine. The third medication that we can use for opioid use disorder is naltrexone. It's pretty difficult to use, especially because somebody has to be opioid abstinent for a while. So in most instances, it's not even an option. And then I openly discuss both methadone and buprenorphine, letting patients know that they're both useful options, and that if we decide on one and it doesn't work, we can use the other one. And then we describe, I ask them, in 2019, most individuals have tried one or the other or both. And it's not unusual for someone to say, yeah, a couple of weeks ago, I was feeling withdrawal, and a friend gave me some buprenorphine and I tried it, and it did help my withdrawal symptoms. So I find out what experience patients have had. I would want to know what kind of experience Harry's had before, in trying to treat withdrawal, and did he have success?
And maybe to follow up on that, what would, for someone who maybe is treatment naive, what would be the logistical advantages or disadvantages of methadone and buprenorphine? And is there any other eligibility of what patients can receive either? And even more so, what providers could actually prescribe the methadone or buprenorphine? Can you talk a little bit about the differences in delivery?
Sure. So the history of treatment of opioid use disorder is really until the 1960s, that as a physician, if someone came to me in opioid withdrawal, I couldn't do anything. Since the Harrison Narcotic Act about 100 years ago, it became illegal to prescribe an opioid to give treatment to someone with opioid use disorder. In the 1960s, we had methadone treatments that came as an option, but that again was not in the physician's office. That had to be at specialized treatment centers and had specific rules that initially the DEA and now SAMHSA have treatment guidelines, and they're again specially licensed treatment centers. They have rules. In general, the rules are that you have to have used opioids for at least a year. That you have to be at least 18 years of age. The first 90 days, you have to show up daily, which is an obstacle for some individuals, that you have to show up on a daily basis. And there's generally some requirements related to counseling and groups. Buprenorphine, which was first presented as a option for treatment of opioid use disorder in a paper in 1978, first came close to fruition as a treatment in 2000 when a bill passed Congress allowing that a medication, which wasn't named in the bill, could be used for the treatment of opioid use disorder in the medical office setting. So it was the first time that someone in the office setting could actually treat. It required an addendum to the DEA license with an 8-hour training course. Initially, it had to be in person, and then could also more recently be online as well. And the rules that were slightly different, whether there was no rule for duration of how long a person had opioid use disorder, that the age was now 16, so it was a lower age, and that it was initiated it could be initiated in the office or by prescription. At the beginning, most of us had patients come to the office to get their first dose. But again, it was by prescription, initiated in the office, and there had to be the availability of counseling, although not required. It could be individualized. And the original cap for the number of patients that could be treated with buprenorphine was 30. This went to 100, and now it's 275. And the other option that has changed is that as of a year and a half ago, that other healthcare providers, including nurse practitioners, physician assistants, and more recently nurse anesthetists and nurse midwives, can also be prescribers of buprenorphine.
And all that is the X waiver, I feel like, right? That's important we've talked about that on the show before, but the addendum to the DEA is the X waiver.
Correct.
So that's talking about using it, because buprenorphine can be used for pain outside of treating opioid use disorder, correct? So the instances you were just talking about and the X waiver are specifically talking about it for patients who have opioid use disorder.
That's correct. So parenteral injectable buprenorphine was available long before, and was certainly used as an effective medication for pain with decreased risk of respiratory depression. And it's interesting, as a sidelight, when my cat got fixed, we got some sublingual buprenorphine to put under his tongue after his surgery.
Weird.
Right, because there's like a transdermal and buccal formulation. Can you talk about some of can you talk about how would buprenorphine be available to these? Like, what are the formulations that people might be prescribing if they're using it for opioid use disorder?
So I'll just take out that the patch form is only indicated for pain. So the formulations that are indicated for the treatment of opioid use disorder are the sublingual film or tablets. There's brand names, there's generic, there's a couple different brand names. A buccal film, which is not really caught on very much, although is available. And then more recently, there's an injectable form of buprenorphine that's given monthly.
Paul,
Wow.
Paul was telling me, Paul, can you talk about the experience? Like, do some of your patients have like a preference?
Yeah, thank you for asking. I was just going to ask that. My patients invariably prefer the films, and I don't know if this varies from state to state, but a lot of times that requires a prior authorization and failure of the tablets. But the patients often report with the tablets, to me at least, GI intolerance, or it just doesn't work as well as the thing I hear more often, but mostly it's the throwing up, sick to their stomach, and they just don't feel it's as effective. So my patients 9 times out of 10 prefer the films, and we end up doing a prior authorization for that. And I'm not sure if that's the usual experience or if that's sort of geographic.
The sublingual films, right? Not the.
Yes, correct.
Mhm.
Okay.
Yeah, and it depends on state, as you said. There is now generic film, brand film, and brand film, generic tablet, brand tablet. The advantage of the film is it's like a breath strip. It dissolves pretty quickly. And before we had the film, we used to have to do a lot of coaching to tell people to tilt their head forward, to pull saliva behind their front teeth, bottom front teeth. And that we used to say that some people were slow dissolvers and some people were faster dissolvers. Some people didn't like the taste. So in general, most patients do indeed prefer the film.
I remember actually in Maryland, they had a quick policy change where the Medicaid no longer covered the film and only the tablet because it was being smuggled into prisons. And so some of our patients had to switch from the film to the tablets. And it's a fragile population sometimes on those medications. It caused a lot of issues. And
so that was a short-lived issue. Actually, was interviewed by NPR.
Yeah, you wrote about this, I remember.
Yeah, I wrote it, and I was on a story where NPR came to my office to interview me, and
Amazing.
It quickly got changed.
Oh, that's great. Yeah.
Mike,
wow.
Mike, this is something that I mean, we're talking about formulations and we're talking about types. What is the cost to the patients? And a lot of the times, these are patients with either no insurance or on insurance, or on Medicaid, or their Medicaid application is kind of being processed. How hard is it to get this covered?
So in general, it's obviously easier in states that have had Medicaid expansion. So in many states, Medicaid has been mandated to cover buprenorphine. In the state of Maryland, it does, although sometimes formulations. But there's many states have had bills especially because the opioid overdose epidemic, mandating coverage for all Medicaid patients. Now, Medicare D plans, it's probably the only place where I still occasionally we actually have someone in our office who does the prior authorizations. Most commercial insurances now mandate also coverage for buprenorphine products without prior authorization.
That's great.
Without insurance is the harder part.
Okay. And that means it's in out of pocket, or you have to find like a charity of some sort to cover it, or?
That's correct. And just as an aside, state ADAP programs or aid drug assistance programs, which are state by state, all cover buprenorphine as well. So in Maryland, that often is an issue we have some undocumented individuals with HIV that we take care of who their health insurance is through ADAP, and we can cover buprenorphine there as well.
So we're getting fairly granular here. I'd like to take a step back. I feel like a lot of the hesitation with people sort of starting prescribing buprenorphine is just concerns because you have to do this mandated training, and then you have to be very cautious about how you initiate, which we'll get to. I guess sort of broadly, can you sort of address if there's any safety considerations for buprenorphine?
Sure. So the first thing I always ask is what's happened before when you've taken buprenorphine. Most individuals know that you have to be in withdrawal before you can take it. It's it's in the street, and related. If someone says, "I think I'm allergic to buprenorphine," it's usually because they precipitated withdrawal. So buprenorphine has a stronger affinity for the receptor, so it knocks any opioids off. So you have to be in moderate withdrawal in order to take your first dose. And there are some people who feel with many of the opioids being fentanyl that you should wait even longer. But I don't have a specific rule for hours, or somebody told me, well, I tell my patients to wait 2 days. I mean, you're going to fail if you wait for 2 days. What is that? So it's really the degree of withdrawal. If they're uncomfortable and they know what that is, and they're really craving, they're sweaty, they know better than we do what significant withdrawal is, and they put a dose under their tongue, they're going to feel better within minutes.
Are there other safety issues at all?
So there are no other safety issues. In fact, There's no significant drug interactions, which is an issue for methadone, where we do worry about interactions with other medications. I've occasionally had patients actually referred because of having Q2 prolongation on methadone and assistance in switching people from methadone to buprenorphine. That's a common in-hospital consult request for assistance. It's really safe because there's no interaction with other medications. We used to, when we first started doing it, people used to say you have to monitor a liver function test. There's no evidence of liver toxicity. And someone who has perhaps decompensated cirrhosis, like any other medication, you would be cautious. But in general, it's very easy to use. And I certainly think it's easier to get someone started on buprenorphine than to get someone started on insulin.
What's the specific concern with the decompensated cirrhosis?
That I think that perhaps the metabolism may be slightly diminished in people who have uncompensated cirrhosis. It's not a contraindication, but I would probably start at a lower dose.
Gotcha.
Mike, I just wanted to, because we've had a couple patients admitted to the hospital with opioid use disorder. There was a hepatitis A outbreak near Kashlak. So patients might have had high liver enzymes. They weren't necessarily in failure, but we didn't know, because if you look it up, it's still in there in like the adverse reactions or the contraindications. And you can find some case reports of like patients that were on buprenorphine, naloxone, and then they had liver failure, but they had multiple other things that could have potentially caused the liver failure as well. So it wasn't necessarily proven to be causal. So you're saying that patient with like liver, like unless they're in fulminant liver failure, you're not really worried about buprenorphine throwing them into it.
That's correct.
Okay. That's good to know. Yeah, because there have been a couple cases in the past year or so since Kashlak has gotten this medicine where the patient was not given, they weren't offered bupe because like our pharmacist didn't know, and what we from what we could look up with no one having much local expertise. I don't know, Paul, is that happening at your hospital too? I guess.
I've not seen that, but luckily we have a toxicologist who's sort of spearheading our substance use disorder initiative. So that's helpful. But Dr. Up to Date, I can imagine if you're rate limited by that, it would be a problem.
Yeah. No, I mean, there's PubMed and looking around and stuff. I couldn't find anything to, okay. It's good to know. That's why we're doing this.
And what dosage? You mentioned that you'd have to reduce the dosage in maybe severe liver failure, but what dosage would you start these patients on who aren't in severe liver failure?
So in general, I tell people to take the first dose being 4 milligrams. The most common is I tell patients to take 4 milligrams, and if they're doing well, depending on the time of the day, to take another 4 milligrams later in the day, and then on the second day in the morning when they wake up to take 8 milligrams. And I'd say 90% of patients, I have 16 milligrams a day. I don't go beyond 16 milligrams until we know, probably even a week out, that somebody says that they're still kind of struggling and craving. I never go above 24 milligrams. And then the other way, I have a few patients who I actually saw a young woman today who has done well long-term on 4 milligrams.
And very granular, specific question that we can certainly cut out, but do you find insurance companies are paying for the 4 milligram tablets? Because that's not been my experience, at least in Kashlak's neighborhood.
I think it's individual. I think you have to see. Sometimes it's the other difficulty. Sometimes pharmacies. I have one person who, this is a different issue, we're coming off very slowly, and it comes in a 2 milligram tablet, and that person has to order as well because that's not a common dose.
We've often initiated people on to stay in the 8 milligram film, but cutting it in half. Is that something that you guys do? That seems like an easy way to.
I do too, but the important thing is generally I tell people to cut it in half while it's still in the foil. It's just the handling. If you have your hand,
that's a fair point.
Or it has some oil, it can make some of the film dissolve in your hand.
Ooh, that's a good pearl.
Cut it in half and then peel the foil open and use the half.
That's why this is a master class.
Unbelievable.
So what we've talked about so far, we talked about the formulation of buprenorphine. We talked about the kind of a little bit about the initiation, how to counsel patients, and then that essentially buprenorphine's safe even if the patient has elevated liver enzymes or even if they have chronic liver failure. It should be okay. You just might start with a lower dose, and then cut the 8 milligram strip in half, and don't while it's still in the foil. That's fantastic. Justin, what else is on the agenda here? I know we have a lot more questions left.
Yeah. So one quick thing I think it's important to ask about is when you're trying to get buprenorphine in these community centers, which you've been an advocate for, or when people have concerns about patients that are using buprenorphine, is this something that can be frequently abused? If it's on the street, is this something that people are going to be asking for buprenorphine if we start serving them at our clinic, just so that they can have it as a drug of abuse, like another opiate or narcotic?
So obviously, I think we should protect this, and we don't want anybody to say that this is something that's just abused. So I don't think diversion is something that's good. I don't encourage it. But in fact, diversion is generally because we need better treatment access. So if you ask people who have bought buprenorphine on the street why they bought it, it's because I was in withdrawal and I wanted to feel better. If someone wants to get high, they're going to buy some heroin/fentanyl on the street, which is also cheaper on the street than buprenorphine.
Wow. What?
Well, and there's a great article, right? I think there's they did evidence where they interviewed people, and it's something like less than 10%. I think it's even smaller that used buprenorphine on the street, used it for any type of attempt at euphoria.
Yeah. In the streets of Baltimore, it's $6 now to buy a pill of heroin/fentanyl. 2 years ago, you couldn't get anything really for less than $10. And the buprenorphine on the street is about $10.
Wow. Okay. Well, if we were gonna, do you want to move on to like how we would specifically initiate this? We talked a little bit about it, but let's get a little bit more detailed.
Some details.
Sure. So in general, in 2019, I only do home initiation. There is literature support in one of those where you hate to say this double negative, that home initiation is not inferior. That was the conclusion of the paper to someone initiating in the office. There's problems with initiating in the office. You certainly can't store it in the office because the DEA has rules for storage of scheduled drugs. So early on, people would say, bring back your medication. We'll give you a dose in the office. There's really no reason to do that. If you see somebody withdrawal, why would you wait a day if they're suffering and want to initiate treatment that day? So I give them a prescription. It's individual preference for how long the prescription should be. In general, you have to make a judgment as to when you're going to see the patient back. Is it someone that's new to you? Is it an established patient who is now ready for treatments, who you think is going to succeed? I would never give more than a week, meaning 14 doses of buprenorphine as an initial prescription. And I think you have to make a decision. Regardless of how much you give, I think it deserves a phone call. In my office setting, we have peer recovery coaches who can help with the phone calls. So we often tag team, like the peer recovery coach will call the next morning or even that evening if I see the patient in the morning, send me a message to the electronic health record. And we often tag team checking in with patients. It's a lot of coaching and encouragement. It's really congratulating people who do well and asking. In a trite way, I tell people, they say I'm doing well. I say through the phone, well, pat yourself on the back. So it's a lot of encouragement. I would always see patients in person. At the longest, it would be 1 week, just to judge. And I think it gives personal satisfaction to see patients back in a week because often you'll see they look so dramatically different. They're full of hope. They dress differently. Their conversation is different. And it's that reinforcement which can encourage new prescribers to keep on going. And then in general, again, I ask patients when they show up. I even ask patients on the first visit, we use urine drug monitoring. And I tell patients I use that as a tool that this, eventually we're going to look at your record and see, 4 straight urines that only have buprenorphine in it. And you're going to be really proud of yourself. This is individual style, but if someone tells me, I had a slip yesterday, I'm still using, I say, well, let's not do a urine today. Let's have you come back in a few days when we know, because my pretest probability is 100%. Why would I do the test? So I listen to what the patient says, and but then again, if something is there that shouldn't be there, I don't say I got you or I caught you. I say, looks like you're struggling. To fill me in what happened and what we can do to help things. It's very patient centered. I'm here to help you succeed, so you have to guide me.
Right. This is a disease where they are gonna have, like, almost everyone's gonna stumble. At least that's my experience with addiction. It seems like
Yes.
Seems like everyone's going to stumble. So punishing them for stumbling is not what is not a step in the right direction. When you're talking about they're coming back in and they should always have buprenorphine in their system if they're sticking with the treatment. That's what you're looking for. And then you're also just looking for, are they using any other substances?
That's correct. But we always remind, I think all prescribers need to know that this is a treatment for opioid use disorder. The patient you presented was using cocaine as well. Now, it's possible that along the way, as he separates people in places and stops using heroin, that he'll stop using cocaine too. And that becomes a conversation. I take care of many patients who indeed stop cocaine. I can think of a handful of patients I've treated with buprenorphine for a few years who still intermittently, a couple times a week, once a week, twice a month, still use cocaine. And that doesn't mean they've failed their treatment with buprenorphine.
Right. You've still reduced harm by having them on that medication.
So if I can ask about induction, so you mentioned it's sort of relatively straightforward to start for someone who's actively in withdrawal. They're in the office, they're shaking, they feel awful. How do you go about out of office induction for someone who has sort of recently used and so is not in active withdrawal at the time? What kind of counseling you do and how do you sort of talk them through the initial process?
So I'm first going to say that I prefer the term initiation because I think that there's no other medicine that we use that we induct. I guess you can make your
insulin induction.
You can use your stovetop for induction.
Sure.
Because I think it scares off people because this is something different. Like there's no other medication that we use a strange term like induction. So people come to the office that have already used. It's conversation. Sometimes I may, if they've used it before, I'll trust them and say, you got to be in withdrawal. I provide buprenorphine treatment in unusual settings. I'm in a church Monday morning where we created a program. So someone comes in and says, I used a few hours ago. But I'm only there on Monday. I don't have the option of saying, come back in 2 days or tomorrow. I don't want to find out they overdosed between, today as Monday and next Monday. So we coach, we talk to them about it. I have a nurse who can also check in on them. But we coach and say, you got to be in withdrawal. Don't take this dose until you're in some withdrawal. And I'd say 98% of the time it works. A few times it doesn't because someone misjudges and does take it too early. And then we talk about it then as well.
Let's say we initiate our patient and unfortunately calls the next day and he just says he's feeling awful. He woke up and he's having sort of his typical withdrawal symptoms. He's anxious, his belly hurts, he's having a runny nose, and he just feels awful.
Yeah. So generally what I do is I encourage patients to keep on going. Occasionally, if there's significant nausea, I may actually, and they're worried that over the course of the day, they're going to have persistent nausea. I'll call in some ondansetron or something like that for nausea, because that makes it more difficult. Certainly other supportive medications, like cyclamine if they have a lot of cramping. But in general, I try to give encouragement. I do my best. And I usually go slowly. If they're in withdrawal, generally, they're going to feel better. And I'll probably tell them to do only a 2 milligram dose and do frequent 2 milligram dose, like every couple hours to do. Again, if you have 8 milligram strips, it means a quarter of a strip, but doing carefully, but doing, and it means phone calls, more encouragement. Most individuals have had bad withdrawal. It's certainly not something they want to have. And it can be frustrating. And you do have to give a lot of encouragement that this is going to get better and we're going to succeed in getting you on this medication. And within the next 2 days, you're going to be really glad that you stuck with it.
The 2 milligram, is that just to more gently get them onto the medication? Like if you give them the 2 milligrams, it might be knocking off some of the opioid full agonist that's still in their system. So you're just you're knocking off less at a time than if you were to give like a 4 or an 8 milligram.
So that's correct. So there are even some models where people have looked at people who are on high levels of opioid agonists using minuscule doses, which we can't even do. A pharmacy prepared a 0.5 milligram at a time dose of buprenorphine to try to get people onto buprenorphine who are on high doses of agonists quickly. I certainly wouldn't do that in the outpatient setting.
In talking about the microdosing that you mentioned, Mike, the Butrans patch, which as you mentioned is mostly for pain or only approved for pain, there's some theory behind it, perhaps that might be something that could be used to treat or transition people that are really high risk for precipitated withdrawal. Is that something people are talking about, or is that a thing?
So there was a paper, I believe, out of Colorado where people looked at that. So when you think about it, what it means is that when you put a patch on, it goes into your system really slowly. So you're very slowly getting a level. Officially, it's an off-label use. But in the hospital setting, if there's a need to make that transition, it certainly could make sense.
Cool.
That'll have to be like the master class 2.0 for you to go through that.
Matt, did you want to ask about the induction for chronic pain?
Well, yeah, I mean, that kind of goes along those same lines. We were talking about, I know that some of the other groups at Hopkins where there's a specific pain population on very high doses of prescription opioid pills, they are also transitioning some of those folks to buprenorphine because some of those, anybody that's on long-term chronic opioids can develop an opioid use disorder. For patients in our clinics, we see a lot of primary care patients that just end up on high-dose opioids, and maybe we have some in our panels, we don't know what to do with them, transitioning them onto buprenorphine. Do you have any words of wisdom for how to do that?
So I have tried. I've had some success. There has to be some patient buy-in. In general, I try to get people who are on, I sometimes inherit patients who have been set aside by other providers on incredibly high doses of opioids that I diligently do my best to try to get them down. We work out if there's complaining, then they're saying, see, you did okay, encouragement. But I have successfully treated some patients with chronic pain to buprenorphine and have them report that their pain is the best it's been. I had a lady who had a chronic pain issue and then actually had to have surgery and was given Dilaudid by after surgery, and she reported it gave no pain relief. Within 12 hours of her surgery, she said, "Put me back on buprenorphine and pain relief."
It's great.
Yeah.
Yeah.
Let's talk about that. So one of our second cases, Harry's friend Tyrone Love, is also someone who is stably on buprenorphine and has to go for a elective knee replacement. And so he's doing really well. He's been on buprenorphine for a couple of years now, but is worried about pain management during this elective procedure. Is his being on buprenorphine a contraindication for an elective procedure, or how can we help him handle the recovery period?
So this is an area where, unfortunately, a lot of people will say, "Here's what I do," which I generally hate. At the American Society of Addiction Medicine meeting, there's a pre-course on pain and addiction. And this past year, there was, maybe it's because I agreed with them, there's finally a good discussion of perioperative care of people on buprenorphine, because there's a huge mix of opinion. So I actually had a recent argument with an anesthesiologist who said, well, I want to see patients on buprenorphine 3 days before surgery and start them on full opioid agonists. Have them on agonists for 3 days, then have their surgery, and then a few days after surgery, transition them back. And you can imagine if you're a patient who's in recovery, you say, "Oh my God, you're putting me on an agonist." Then there's also the issue of I'm going to fill a prescription for an agonist, and then my insurance is going to say, what's going on here? Maybe they shouldn't be on buprenorphine. So I think that is not a good tact, even though you'll hear people say it. In general, I do. What was mentioned at the conference as well. And there are some papers. There's been it's pretty tough to do a randomized controlled trial of the best way to do this. But in general, and working with anesthesia, I always have a discussion with the surgeon. And there are some surgeons that I know real well. For some reason, I have a lot of patients on buprenorphine who've had carpal tunnel surgery. So and it's the same surgeon. And we do the same thing with everybody. You gave an example on knee replacement. I think it's the same thing. I tell patients to take buprenorphine the night before surgery, not to take it the morning of the surgery. Know that they're going to get a full agonist perioperatively. And then I have had patients who said even 24 hours after surgery that if I can, I try to visit them too. But I speak to the surgeon and anesthesia, and it's not uncommon for patients to say even 24 hours after surgery, I want to have be back on buprenorphine. I had one lady who was 7 years into recovery, had a hysterectomy, and told anesthesia, "You're not to give me any opioids postoperatively," and she got no opioids postoperatively.
She didn't stay on her bupe during the...
She stayed on her bupe. That's
okay.
Good. So whatever happened postoperatively, but her initial dose after waking up, she only got buprenorphine.
Mm-hmm.
Would you ever go up on the buprenorphine dose or kind of decrease the interval of dosing of the buprenorphine?
So that's a great point. So the analgesic half-life is shorter. So when we give it for pain, I would change it to either every 6 hours or every 8 hours. So that's correct. And I usually use a similar dose. I may go up a little bit. If someone is on 16 milligrams, I might go up to 8 milligrams 3 times a day or 6 milligrams 4 times a day in that post-operative period, or even for a few days after they go home.
And when patients have bupe in their system, if they have acute pain, you can use, would you, if you decide you're going to use a full agonist, would you just give it on top of the buprenorphine, or would you would stop the buprenorphine while you're giving them full agonist? Which one do you think is better?
So in general, that is what I do. There are some individuals who have successfully said that we just give the full agonist temporarily. It's likely to have a diminished effect. So I think you have to make a choice on what type of pain it is. My first option would be to try to split the dose of just using buprenorphine.
Mm-hmm.
And if you're using a full agonist, in general, I would say, and you really want analgesic that you get, and you want the full agonist present to hold the buprenorphine.
Okay.
But there are some people who don't. But I think if you want to truly get pain relief, to hold it temporarily is right.
Okay. Can we go back just to the dosing? This is a question that I had when you're starting somebody. When we were talking about the initiation, you said the most you would usually write for is like a full week. What milligram strips do you write for? And because you don't know that first 24 hours, you don't really know like how much they're going to need each day. If they're going to be a 4 milligram once a day person or an 8 milligram twice a day person, how do you figure that out when you're writing that first script?
So in general, the first script, I do give the dose as 8 milligrams twice a day. And I think probably 90% of people wind up okay on that.
Mm-hmm.
And then it's really a patient, and it's easier to come down. A patient says, I think it made me a little bit too drowsy. And then we cut back. But I wouldn't go up more than the 16 milligrams until people have really gotten for full pharmacokinetic effect, which probably takes 4 to 5 days.
Got it. So you could write them the 8 milligram strips, and they can cut them in half or in quarters, as you told us, and they can then decide like which dose is working, but they won't go above the 8 twice a day.
Correct.
I want to ask about sort of two perceived barriers. One is I think a lot of folks are a little bit hesitant to initiate prescribing because of the perceived requirement for behavioral support services as part of the outpatient practice or connected with. So I wonder if you could sort of speak to that and how big a barrier that actually is.
So that's a really important point, because I think that does prevent some people from prescribing. That as prescribers, we hope that all prescribers, whether they're nurse practitioners, physician assistants, or physicians, have some skill in motivational interviewing and giving encouragements. And that's what's really necessary. And if you look at the literature, there is no paper that looked at in randomized trials where people were assigned to usual treatment, which includes a provider who cares and counsels, and making that a subset of half the patients randomized having to go over there for counseling. The patients required to go over there for counseling had no better outcomes. Having said that, I think that I individualize. And I kind of say, to patients, what do you need for support? And if you can, and I don't think this is requirements. For instance, in my office setting, I have peer recovery coaches available to help give encouragement and to help with the phone calls and checking up on people. But there's no evidence that requiring counseling is of benefit. The other issue which I think is important that individuals will hear, is that so much of addiction has been so 12-step based, and that if someone goes to a 12-step meeting, they're going to hear, well, you're on medication, you're not in recovery. And I warn patients about that message.
Yeah, to follow up to that, I mean, you hear this, like some patients have said to me, aren't I just trading one addiction for another? And would I ever be able to taper off this medication? How do you answer those questions? And how do you answer those questions?
So that's an important question. So very frequently patients will, how long will I be on this? And I say, I don't know. In general, I'd say it's going to be many months, and that we make a judgment. Right now, our goal is to make improvements in your life, and let's see what happens. The pull of families can be very strong as well. This just happened to me a week ago, where a young lady who was, had HIV, actually perinatal HIV, had stopped taking her HIV medication. She was 21 years old, using heroin, advanced HIV, which you shouldn't see. And over the last 4 months, she was on buprenorphine. I was taking her HIV medication, and her mother burst in the room and said, "You need to stop prescribing her buprenorphine." Essentially the same thing that you just said. You're just substituting one thing for another. I don't want her on it. So in a way, it was good because it was overt, and I knew this message had been given to her. But I think we have to discuss with patients and realize the patients may hear that at home.
It sounds like there's not really a great way to combat that, other than just to tell them that we don't see it that way. We think that their chances of surviving this disease is better with the medicine than without it, and that this is a chronic condition that needs to be treated. It's, I guess, and then as far as coming off the medicine, you've been doing this for a long time. What percentage of your patients, and this is just like off the cuff, what do you think? Like, what percentage actually come off this medicine years down the line or months down the line?
I'd say I've been doing it since the onset. I'd say probably 10% come off. Okay. And I don't know that it's very different than, for instance, my patients with diabetes. What percent of my patients I start on metformin and insulin and other stuff eventually wind up not on medication? It's probably less than 10%, but yeah. I'd say about 10%. I think that's a realistic number. And in 2019, I openly talked to the fact that this is overdose prevention as well.
Yeah.
I mean, all my patients have seen someone die of an overdose. And I say, if you take this medication, it's going to prevent you from craving, and it probably decreases your risk of overdose if you slip too, because you have it on the receptor already. So opioid use disorder treatment with medication is overdose prevention.
Can I just ask? This is not straight up medical, but somewhat historical. I just want to ask you a question about opioid usage in the West in general, because in the 1800s, morphine was widely available over the counter. So was cocaine and other substances as well, until the Harrison Narcotics Act of 1914, which subsequently a few things happened after that probably had some impact on illicit drug use, one of which is World War I, and then the Spanish flu epidemic. My question to you is, have we ever as a nation really recovered, or is this just a continuum of the same, looking at the 1960s, 1970s, and then even in the 40s with World War II, soldiers overseas utilizing morphine while they're overseas for illicitly. Is this just a continuum? Have we ever been out of the opioid usage crisis?
So I don't think we ever have. I mean, the idea that you can get euphoria and use it as a recreational drug is hundreds of years old. So the formulations have changed. Unfortunately, it looks like we've changed from a agricultural opioid use disorder to a industrial manufacturing use disorder. And there's also been some shifts in socioeconomics, so of who used. So heroin. So William Osler protected William Halstead, who was the famous surgeon at Hopkins, one of the founding surgeons, who had terrible morphine addiction.
Right.
And so 100 years ago, morphine, heroin was a drug of the elite, and cocaine was the drug of the more socioeconomic lower strata. And then it switched. So some of those things have changed. But you're correct; it's been a continuum.
Yeah, I mean, it's kind of funny because like Vin Mariani with Cocaine and Wine, it, had a lot of popular or a lot of well-known users like Ulysses S. Grant, and I think even other presidents too. But I can't. I mean, the illicit, what we consider illicit today, has been used widely for years. I don't know. Maybe the war on drugs has been drug out too long. That was going to be my pun, but
was that question just to set up a pun?
Just a single word, shaggy dog. Oh God.
No, it wasn't. It was a legitimate question.
I'm
pun
so
just
angry
kinda
right
snuck
now.
in.
Justin, please ask your question. Let's get ask your question and let's wrap
I was
up.
going to say, let's do. Yeah, I think we talked about a lot, and so kind of talking about a quick summary for patients with opiate use disorder. Buprenorphine is a very effective medication. It's a very safe medication. It is not frequently abused, and diversion is maybe blown out of proportion a little bit too much as a concern. Can be prescribed in the office, in a church, in a van, with home initiation. 8 milligrams BID, but the first milligrams first. Anyone can get their ETS waiver for free with PCSS online. Clinics do not need intense counseling resources to be offering buprenorphine, and we can treat acute pain on top of buprenorphine, as we discussed. And then maybe using that as a summary, Mike, can you kind of give us some take-home points for our listeners?
So I think the take-home point is mostly the reason I've done this for so long is that I get incredible satisfaction that it's a way to truly team up with patients. I tell patients I'm joining your fan club. We create hope for them, and then the messages I always talk about patients is I tell them about steps that my steps, which is different than 12 steps, is that we're going to take away shame, we're going to remove stigma, we're going to build your self-esteem. And for as long as we're working up together, we're going to work on coping skills. We anticipate obstacles. What are your triggers for relapse? We're going to work at it. This is a work in progress. And for patients to reflect. If you do this long enough, you can have numerous patients say to you, "You saved my life."
And the last question, anything that you'd like to plug, any websites or other resources you want to share with our listeners?
So this is a self-plug, if that's okay.
Sure.
So I'm an author of the American Society of Addiction Medicine Handbook of Addiction Medicine. We're working on our second edition. It's a very practical guide, not a lot of basic science. It's really a approach to how do I, what are the signs of toxicity? How do I treat withdrawal? How do I approach patients? And we're coming out with our second edition next July.
Excellent. I definitely need that. Okay. And we were talking about this beforehand, right? People can sit for the addiction medicine boards. They can buy your book and sit for the addiction medicine boards before 2021, and they don't have to do a fellowship. But maybe do a fellowship if you have the time. And
we're kind of close now. You have to put a lot of hours in between now and 2020. So it's going to be a full-time job if you're going to
2021, Paul. So they got some time. All right.
Never the opposite.
Mike, this was great. Thank you.
Thank you, guys.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Get your show notes at thecurbsiders.com/podcast and sign up for our mailing list at thecurbsiders.com/knowledge food to get our weekly show notes in your inbox.
That's correct, Paul, because we're committed to providing you with high-value practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on iTunes or contact us at thecurbsiders@gmail.com. Special thanks to our producers for this episode, Justin Lee Burke and Steffi Mueller. And to our social media team, Hannah R. Abrams on Twitter, Beth Garbs Garbatelli on Instagram, and Chris the Chew Man Chew on Facebook. I also want to thank myself for writing the music. Until next time, I've been Stuart Kent Brigham.
I've been Matthew Frank Watto.
I've been Justin Lee Burke.
And I remain Dr. Paul Nelson Williams. Thank you and goodbye.